for coming and joining us on a very lovely Saturday afternoon. This is our experiment for this time slot, and we can see that a lot of people are enjoying the weather, but I know that I have the right people here. My name is Colette Canute. I'm the president of the League of Women Voters of Huntington, and I welcome you to this session that I hope that you will find very informative regarding certain myths that exist about the Medicare and the Medicaid program. To get us started, I'd just like to review our objectives for this session. Basically what we'd like to do is to begin to help you understand some of the basic components of the Medicare and Medicaid programs. However, we will be focusing specifically, at least in my presentation, on two major myths about those. The second objective has to do with confirming or refuting some of the leading beliefs that exist about these programs. And then finally, to identify strategies to help you navigate your participation in the Medicare and Medicaid programs. I'm very happy to have two experts, one regarding the Medicare program and Medicaid program. I'm happy to have, sorry about this, guys. I'm happy to have Nancy and Michelle, and we'll be providing you with some specifics about their background. But just to give you an idea, these programs, this is the third in a series of programs in which we've been focusing on health policy. This is an area that you know that has received a lot of attention on the national front, and we felt as though you were hearing a lot of things in the news. Some of the things that you were hearing were very accurate. Some of them were not very accurate. We felt as though the League of Women Voters were in a very good position to provide you with as accurate and balanced information that's possible, particularly given our nonpartisan policy in which we do not support or oppose any particular political party or political candidate. We want you to have information so that you know how to take action. So as you're listening to this program, if there's something specific that is of importance to you, make a note of it, because that may be exactly what you want to communicate to your representative. Now, just to be totally transparent, the League does support a single-payer concept. And as some of you may know, the single-payer concept has multiple schemas. But one that we are supporting is one that simply best supports equitable access and contains costs. We feel as the League that this is the best approach to implementing healthcare financing to the American people. To tell you a little bit more about transparency and who I am, I told you that I am the president, but I also am a citizen, and I'm also a patient who has great interest in what's available to me as a patient in terms of keeping the costs down of insurance, making sure that the type of care that I receive is of the highest quality, and also I'm very interested in making sure that that care is accessible to me. So let's start off with what I consider some of the two biggest, hairiest myths about Medicare and Medicaid. As you can see, I like my monster. He's definitely a scary looking, not too scary, but a pretty scary monster. Let's start off with the first one. This is the one that we hear all the time, that Medicare is running out of money. You hear words like Medicare is going bankrupt, Medicare will not be able to support the people who are currently receiving it. So let's see what's the truth behind that myth. Is it a myth or is it not? Let's first look at the components of Medicare. Medicare basically has three components of how revenues are poured into the program to finance the recipient's health care. The first is Medicare Part A, which all of us know supports hospital care. So anything that's associated with going to the hospital is what's paid out of that fund. The Medicare Part A Trust Fund, as you can see by this chart, over the years its solvency has changed in terms of when it's going to run out of money. Currently, they're projecting that Medicare Part A Trust Fund will have a shortfall in 2028. We can see that there were some improvements in terms of the length of the solvency of the trust fund in the years that began ACA. The solvency was extended out to 2030. But the most recent projections show that there is now 2 years less time that we have to wait before we actually see some issues in terms of shortfalls of revenues for this particular fund. But like most things, the answer isn't that simple. We really ask ourselves, where is this money going? And how much is it actually costing us to receive this care? And really, the end-all question is, how much are we willing to pay? Now, I talked a lot about the Hospital Insurance Trust Fund, and remember, that's the trust fund that they always speak of when they talk about this insolvency or the solvency of the Medicare program. But there are two other pots of money that fund Medicare services. One, the Supplemental Medical Insurance Fund. Out of this fund, we receive a revenue to finance Medicare Part B, which focuses on medical care, such as the type of care that you receive from your doctor's office, lab tests, etc. And Medicare Part D, which is for prescription drugs. Now, one of the things we know about Medicare Part D is that that is an entirely voluntary program in which you pay premiums to receive that benefit. When you usually sign up for Medicare, what you receive is what they call original Medicare. That is Medicare Part A for hospital care and Medicare Part B for medical care. There's a third fund, and this is a fund that is financed completely by premiums. These are Medicare Advantage plans. These are these supplemental health insurance policies that many of us purchase so that we can cover some of the costs of our care that Medicare don't ordinarily cover. These are private plans that are approved by Medicare, and you pay premiums to receive these. Now let's look again at Medicare Part A. Notice, what funds Medicare Part A? I talked to you about that. Hospital. Payroll taxes are used to pay for Medicare Part A. Taxes that are paid on Social Security benefits, if you are paying taxes on your Social Security benefits. Other revenues include interest that's earned on the fund's investments, and then premiums that are paid for people who aren't eligible for a premium-free Part A. For the Supplemental Medical Insurance Fund, Parts B and Part D, these are premiums that are paid for people who are receiving this coverage, but they're also paid out of funds that are authorized by Congress out of the federal general revenue, and then as well as interest that are earned on these funds. Now, let's look again at the sources of revenue in which these funds depend. Now, if you look at the first bar, this is total. So this is totaling the funds that are used to support Medicare Parts A, B, and D. We're not including C because, once again, those are those supplemental insurance policies that you pay for out of your pocket completely. We do know that Part D also has premiums attached to it. But now let's look at Part A and see what the breakdown is. As you can see, the majority of the revenue comes from payroll taxes. That's what you see at the top, 88%. Only 7% are coming from taxation of Social Security benefits. People who make more and their Social Security benefits are eligible for taxation. And only 3% are coming from other sources. For Part B, 73% are coming from payroll, from general revenue. And once again, that is money that is not earmarked for any particular program. This is money coming out of the general federal revenue. This is money that is based on the status of our gross domestic product. So this money can vary. And how much money comes out of the general revenue is based on whatever shortfalls that Medicare Part B, and as you can see, Part D, cannot cover through premiums. Now let's look at the growth rate. How much spending do we anticipate in these three programs? We're looking at a growth rate of 3.2% for Part A. And if you look at Parts B and Part D, the growth rate is much stronger. 4.6% growth rate, 5.8%. Right now, per beneficiary spending for Part A is at $5,000, roughly $5,000, $5,500 for Part B, and $2,203. And you can see how it's projected all the way up into 2025. All of them go up, but Parts B and Part D, Part B being medical coverage for going to see your doctor, and Part D for pharmaceutical coverage. So, the answer is true. There are solvency issues, but particularly in Part A. And the real reason behind it is that there's no provision currently under law to cover Part B through a shortfall through general revenue transfers. There would have to be a change actually in legislation to be able to use general revenue to cover the shortfall that's being projected for Part A. We don't have that issue with Parts B and D. But there are concerns about the spending that we're seeing and the growth of costs associated with Parts B and D. The more spending that we see in these Medicare parts, of course, the more general revenue will be required to make that shortfall. So, really what it is, it's a matter of how much we're willing to spend. This is how Social Security, Medicare, and some other programs compare in terms of how much it is as a share of the federal budget. Currently, Social Security is costing about 24% of the federal budget, where Medicare is at 15%. You'll also see some other programs, particularly Medicaid, in which we will be discussing, at 9% of the federal budget. When we look at the defense budget and non-defense discretionary budget, we can see how these things balance out. So let's talk about the next bugaboo. There's fraud and abuse in Medicare. Almost anyone that you talk to, they will tell you, this is a serious issue in Medicaid. Is that there's too much fraud and abuse, people are cheating the system, and so let's find out whether this actually exists. First of all, let's look at Medicaid. Medicaid currently they're reporting 9.8% of their payments are improper payments. Out of $466.6 billion of correct payments, approximately $50.6 billion are improper payments. That's a lot. Some people would say a lot, some people would say that's not a concern, but most of us would say it's just that any improper payments are too much. Medicare, however, also has issues in regards to fraud and abuse, and I just wanted to make this as a side note. There have been efforts to reduce improper payments in both the Medicare and the Medicaid programs, but currently what we're seeing is that there's a decrease of 12.1% in 2015 to 11%, and this remains within what they call the statutorily defined compliance threshold. So there's already certain regulations in line with an acknowledgement that there will be some improper payments. But we also see some improper payments in regards to Medicare Part C. And remember, Medicare Part C has to do with those supplemental insurance policies that are sold. But we do also see some improvement for Part B with the pharmaceutical. Now I'll talk a little bit more about the efforts that the federal government has made in terms of trying to reduce fraud and abuse for both of these programs. So my myth was, well, there's a lot of fraud and abuse in Medicaid. But once again, the answer isn't simple. We really have to ask ourselves is who is defrauding and abusing Medicaid. Some people have certain perceptions where this fraud and abuse is coming from. But we also have to ask is how are we letting this happen? And what are we doing about it? Let's look at the three categories of fraud and abuse that are reported out of the Centers for Medicare and Medicaid. They identify three. Provider fraud, those would be physicians, hospitals, any type of medical provider that is giving a patient care. The second category is insurer fraud. Those would be policies that are approved by Medicaid and that are provided to Medicaid patients to finance or manage the financing of their care. And then finally, enrollee fraud, the people who are actually Medicaid recipients. So let's look a little bit more, provider fraud. Now, provider fraud, a traditional method of paying for medical services under which providers are paid for each service rendered. This would actually be your doctor submitting a bill to Medicaid for a service that is rendered. The three types of fraud that are most frequent for this particular category have to do with billing for services that have not been provided. There are also issues with kickbacks to suppliers. And then overprescribing, something that we see in the news constantly. In regards to insurer fraud, the types of fraud that we see are overstating costs or misleading enrollees to believe that they are covered for a particular service. And when the Medicaid enrollee actually goes for the service and that bill is submitted, they find that it is not covered by that policy. And then also charging for non-covered services. Now, certain states contract with health plans to manage their financing, and they may have different schemes for how they pay these insurance companies to actually pay for the services. So you'll see that differ from state to state. But all of this information is rolled up and reported back to the federal government. And then finally, the last, enrollee fraud. And the kinds of fraud that we see most frequently, or the kinds of fraud that are actually tracked by the federal government, have to do with people who apply for Medicaid but are actually ineligible. So at some point they received services, but it was found at a later date that they were ineligible. Some people may go and request Medicaid support, and they may overstate their liability. And then finally, and this is the one category that I find probably the cloudiest, is that people who are eligible for Medicaid, but they claim an ineligible service, which makes me wonder how does that get into the record? Apparently the service was rendered, someone submitted a bill, at some point that person thought that they were eligible and the provider thought that they were eligible for receiving that service. I was talking to someone else about this, and I believe that there's a possibility that there might be some overlap with this last category of eligible but claimed ineligible service and insurer, and what insurers are telling them they're covered for. That's just my analysis. So let's look at what the government is reporting in terms of Medicaid improper payment rates for these three categories. For fee-for-service, that first row, FFS, you can see that the improper payment rate is at 10.6%. And that adds up to a total of improper payments of $35.4 billion. Now, the federal share of that is 20.3. So once again, that 35.4 is state and federal share combined. Looking at managed care, these are the insurance policies that we talked about. Now, their improper rate payment is very low. It's at 1% or less. And the improper payments associated with that are at $0.2 billion. And the federal share of that is at $0.1 billion. Now, in regards to enrollees, where we see eligibility, the improper payment rate is much higher than what you see with managed care, but much lower than what you see for fee-for-service. Once again, physicians and hospitals charging Medicaid for the services that they provided to that Medicaid recipient. The improper payment rate for enrollees is at 3.1%, which spells to $16.1 billion, and that the federal share of that is at $9.2 billion. So what we're seeing is an overall improper payment rate of 9.8, total state and federal improper payments totaling at $50.6 billion, with the federal share being $29.1 billion. Now, I was looking at that report, and I was also looking at a report that came out of an audit from the United States Government Accountability Office. You know, one of the things that you always know about government and the military is that everybody's checking everyone. So there's always an audit of the auditor. And the auditor of the CMS report is the Government Accountability Office. Now, I could not find the data behind these numbers, but they said that the method that they used was by actually approaching each state to find out what their records were of improper payments. And they are now saying is that they see that there will be an increase from $2.1 billion in federal spending for Medicare in 2015 to $36.63 billion in fiscal year 2016. Now, there is one note that I need to make, and I think this is an important note. In 2000, for the 2015 and 2015 reports, it did not really include a report of the Medicare expansion program. And I'm going to tell you a little bit about why I think that happened. But basically what it was is that CMS did not have adequate data to report on the impact of Medicaid expansion on fraud and abuse in that program. So there are estimates. Oh, and I should tell you one more thing about this. It may not mean a lot to you, but it means a lot to me. These estimates are based on samples of the total number of payments that go out on Medicaid. And this is a system that they have used over the years to generate this information. Now, behind these numbers, you'll notice is that where we see the greatest amount of fraud and abuse in the Medicaid program is really on the state side. And in doing this research, I was able to find some testimony from the Inspector General's office out of the U.S. Department of Health and Human Services that basically spells out, and this is also reflected in the Government Accountability Office's recommendations about what seems to be going wrong. And really a lot of it has to do with the states. The states have not fully enacted all of the regulations that have been put in place by the federal government to try to reduce fraud and abuse in the Medicaid program. The federal government often does not get all of the data reported from the states so that they can make good estimates of what is happening in the states. Medicaid, and there's inaccurate data and there's missing data. The state Medicare fraud control units also lack the ability to investigate and prosecute patient abuse or neglect in non-institutional settings. So if you're in a skilled nursing facility, Medicare fraud and abuse investigators have more power when you are in a setting such as that, as opposed to when you have some type of interaction with a private physician or in a hospital setting. Now, Medicaid providers terminated from one state, there is a problem in tracking these, where a person is terminated, let's say in the state of New Jersey, they move to the state of New York, and that Medicaid is not followed, that record is not followed. That is a problem with the system, the data system. And then states did not always suspend Medicaid payments to providers suspected of fraud. One of the things that I had seen was that states oftentimes did not really check to see whether this was a fraudulent payment. They weren't as vigilant as they may have been. Now, a lot of this has to do with resources, but a lot of it has to do with how states manage their Medicaid programs. And I think this is an important thing to hear today, because one of the things that we are hearing is moving more responsibility on states to manage their Medicaid programs. But when you see this very hard data of where some of the problems are really occurring, it seems to be occurring on the state side. So clearly there has to be something done to reduce fraud and abuse for states if more and more of the costs of Medicaid is put on their shoulders. So my answer to this is true. Yes, there is Medicaid fraud and abuse, just as there is fraud and abuse in the Medicare system. But in the case of Medicaid, It seems as though the problem resides primarily at the state level. Now, I told you I was going to tell you a little bit about some of the enforcement efforts that had happened after the passage of ACA. ACA increased the budgets that were available to the federal government to enforce these programs to reduce fraud and abuse in the Medicaid program. In 2016, they removed an estimated $608 million of $8.6 billion identified in questionable Medicaid costs. Now, an estimated $660 million in questionable reimbursement was averted because they were vigilant in looking at those records. There has also been additional funding for healthcare fraud and abuse control. This is a program that was initiated right after the passage of ACA. And really what it was to change this method of trying to deal with fraud and abuse in this program from something they call pay and chase to basically anticipating where there's a more potential for fraud and abuse in the first place. And in my review of some of the proposals that are coming out for the continued reform of U.S. healthcare policy, this is a policy that I see consistent across in that particular, and for those particular proposals. So, that's me. I think I just busted 2 myths. Unfortunately, it wasn't a clean bust, but it gives you an idea about fraud and abuse with Medicaid, as well as what's going on with Medicare. I hope that you all had an opportunity to take the glossary that was provided at the table when you entered, because all of those terms that I just used, I have in that glossary for you to review. And so now I'm going to turn to hear what our experts have to say. We're going to be talking to Michele Albohn from Inputs Medicaid. And let's see. If I can take just a snapshot. Let's see if I can get this up. So this is a PDF. Thank you. Sorry.
Good afternoon, everybody. I'm Diane Slavin. I'm the co-chair of the Educational Task Force. I see a lot of familiar faces in the audience. Thank you for coming out today and competing with the sunshine, which is kind of a hard thing to compete with, since given the way the weather has been. Anyway, I want to introduce Michele Albohn, who is the founder and president of In Good Hands Medicaid Consulting, LLC. She has over 12 years of experience with New York State Medicaid as well as elder care. She is a former Suffolk County Department of Social Work Services examiner. She's also been a supervising Medicaid paralegal and a nursing home director of admissions and Medicaid. She's also a certified Medicaid planner, which is issued through the Wealth Preservation Institute. Ms. Albohn received a degree in healthcare administration from SUNY Empire State College. So without further ado.
Thank you. Hello. Thank you all for coming out.
Michele, I think if you close the laptop, you will move it. Better.
So like Diane explained, I've been doing Medicaid for over 12 years now, and I've had most of my specialty is with disabled individuals and those over 65. What my company does, we assist those who are disabled or over 65 and ill get Medicaid to pay for their medical expenses. Most of our clients are looking for home care, or they're looking for nursing home care. So this is my clientele. What we have found is that there's a lot of myths, not only about the fraud and spending on Medicaid, but there's a lot of myths as to what Medicaid is and how you get Medicaid. Most people don't even know the difference between Medicare and Medicaid. Seems like most of you are pretty educated as to that fact, where Medicare is something that you receive through the federal government. Medicaid is a federal and state funded program that you have to be determined eligible for. So what my company does is assist families to become eligible for Medicaid when the time comes. Most of us don't want to think about the time where we may need assistance with activities of daily living. We don't want to think about needing someone to help us get dressed, let alone a spouse or loved one. So most people aren't prepared for this. There are long-term care policies that people can purchase that can offset some of this cost, but they're very, very expensive plans, and they also don't cover enough of what care costs. The average yearly expenditure for home care is around $80,000 a year, and for nursing home, it's well over $180,000. So these are very exorbitant costs, and these are the costs that Medicaid picks up. Medicare doesn't pay for any custodial care at all. So a lot of people come to me and say, well, Medicare is going to cover the aid. I don't know why Medicare isn't paying my aid. Well, Medicare doesn't cover an aid. What Medicare will cover is your skilled care that you may need after a short rehabilitation stint, occupational therapy, things like that. Medicaid is the primary payer for your custodial care, the aid that you need in the home or your nursing home care. And that is actually the biggest cost for Medicaid throughout New York State. Our seniors take up most of the cost for Medicaid currently. One of the big changes in Medicaid has been the Affordable Care Act, which has affected not only people under 65, but those over 65. Because what managed care does for seniors is a longer process to qualify them for Medicaid, and there's also a in-home assessment by the state to also prevent fraud. So this is one of the processes we have to help people go through. Obamacare, Affordable Care Act, there's 3 types of Medicaid. So that's the first type, where it's basically low income, there's no resource check, you pay a premium based on your. Then there's Community Medicaid. Community Medicaid is for those who need home care, they want to go to a medical model daycare. There's also Medicaid assisted living programs, which many people don't know about. We have a shortage in Suffolk County. There's only 2 in Suffolk County, with 1 opening up in Wisconsin in October. And then there's about 5 in Nassau County. These are very good programs and very well-needed programs for our seniors who maybe don't need nursing home care, or maybe don't have a home to live in, but they do need that assistance on a daily basis. So Medicaid does provide homes for these people who are eligible for this program. Then there's nursing home Medicaid, which everyone hears about, which is the 5-year look back. Currently, there is a 5-year look back. They've been looking to do a 7-year look back, and thankfully that hasn't happened. It's been enough work with 5 years. That's also where they assess penalties. Okay, and we'll go into a little bit more about these specifics also. Medicaid is a very, very beneficial program for my clients, because a lot of times someone comes to us where a spouse is very ill, or it's a parent and they've spent all their money on paying for care, or they're close to spending all their money, or all the kids have been coming together to take care of mom or dad after work. before work, on weekends. They're getting burnt out. They're getting sick themselves over doing all of this additional care. No one also wants to be the one to change a diaper for a loved one. So these are very, very unfortunate, very difficult things that I have to talk to people about every day, but it's a reality. So what Medicaid does is helps families to be a family and to get the help that they need without breaking the bank. Seniors are on fixed incomes. They can't afford to pay $20 to $25 an hour for aid. We're seeing a lot of people who are basically taking the least amount of care possible. They're taking 2 or 3 hours a day and leaving their loved ones unattended for long periods of time. We have people who are left alone because they can't afford it, and they're found on the floor for days. No one knows if they're there. We also have people who try and go to the bathroom, fall, and they're in the bathroom stuck for days. So we can't have our seniors who's worked all their lives to be treated in this way. They need sufficient care. Do we have a perfect program? Absolutely not. But it is a very beneficial program. So what we do is we assist our clients in becoming eligible for Medicaid. There are income and resource limits. Currently, a single person who is applying for Medicaid is allowed to have $845 a month in monthly income. Your monthly income includes your Social Security, your pensions, your IRAs, and any interest income you may have from trusts, your local trust. Now, a lot of people think that just because my pension is $1,200, I can't get Medicaid. Well, that's untrue. Medicaid has a program which is called a pooled income trust. Some of you may or may have not heard of a pooled income trust. But a pooled income trust is run by a nonprofit organization that allows a Medicaid recipient to keep all of their income above the $845 income threshold, which is a big savior for anyone. Most people need their entire income to pay for bills. What Medicaid says is that if you do not use a pool trust, you have to pay anything over $845 to them as a premium, which can be costly. Some people may only have a $1,200 income per month, but some people do have a $3,000, $4,000, $5,000 income per month. So this is something that they can't afford either. So a pooled income trust is a way for an individual to keep their monthly income to pay for their non-medical expenses. And then they're allowed to have an aid, go to a daycare program, or live in a Medicaid assisted living program at no additional cost to them. Now, as far as resources, a single person who's looking to go on Medicaid this year is currently allowed to have $14,850 in total resources, which is your checking, your savings, your CDs, your stocks, your bonds, the cash value of any life insurance policies that you have, and any other investment vehicles. So this is a very low threshold, but back in 2006 it was at $4,000, where you're only allowed to have 4,000 total resources. A big misconception is that if you have over $14,850, you cannot apply for Medicaid, which is also untrue. You can have assets over $14,850 and still apply for Medicaid. We put together financial plans for those who have excess resources in order to qualify them for community Medicaid. Since for community Medicaid, we can make you eligible for Medicaid in the current month to secure Medicaid the following month. Community Medicaid only looks at your current resources. So if you're looking for coverage in the month of April, they're only looking to start with April resources. A lot of people don't know that. Nursing home Medicaid is much more difficult. It entails a full 5-year audit of every single bank statement and transaction that you have had, and any account, open or closed, in the last 60 months. So what that entails is our office going through every deposit you have ever made in the last 5 years, and every withdrawal you ever made in the last 5 years, and then requesting those documents from the bank. It's a very long and tedious process. What Medicaid is also looking for is deposits that you're making that look like you may have additional accounts in other places. They're looking to see if you've given any of your children or grandchildren any money, whether it may have been for a birthday, a college graduation, or a wedding. They penalize you for every dollar that you give away. Then what they do is for every $12,811 you've gifted or given away, which is considered an uncompensated transfer, they penalize you for 1 month of non-Medicaid coverage. So if you've given away $14,000 per child per year, as per IRS regulations, you've gotten over your gift tax responsibility. But as far as Medicaid is concerned, you're looking at months of paying penalties for not having Medicaid coverage. A lot of people also think that you also need an attorney to apply for Medicaid. In the state of New York, that is not true. You don't need an attorney to apply for Medicaid. Other states, such as New Jersey and Florida, do require attorneys to apply for Medicaid. As long as you have someone who is knowledgeable about Medicaid and the regulations regarding Medicaid, you'll be in a good position. Medicaid is not for the faint of heart. There is a lot of misconceptions. There are time constraints. Each county does different procedures with Medicaid. Suffolk County is currently doing a pilot program for anyone applying for Medicaid, which means they take your Social Security number and the Social Security number of your spouse, and they run it with every bank in that county, or actually on Long Island. So a lot of times they're finding things that you might not even remember that you have. If this pilot program goes well, it'll pass through for all the counties in New York, and hopefully that will happen. As far as fraud, we talked a little bit about fraud. I haven't seen much by the way of fraud with seniors. When I worked for Medicaid, I did see a lot of fraud with low-income population. But our seniors go through the most with applying for Medicaid and the procedures to become eligible for Medicaid, as opposed to those who are just looking for basic health insurance. I think the Affordable Care Act has helped prevent fraud greatly, as some of the numbers that Colette was talking about do confirm. But one of the processes of Medicaid becoming managed is that it's capitated. So basically each health insurance company, and there are about 12 on Long Island that are contracted with the state of New York to provide Medicaid services, receive one fee, which is about $4,200 per person. So for $4,200 per person, that insurance company has to provide all the care that that person needs, which is a 3-hour-a-day aid or living, which is diapers, which is daycare, prescription drugs, transportation. That's a lot of care for a very little amount of money. So I think one of the things that needs to be corrected in all of this is to help these insurance companies, work with them to find out exactly what it is that's going on. They are doing assessments in the home. There is no fraud when it comes to our seniors. I have not seen any fraud when it comes to our seniors. They really do need the help. And the Affordable Care Act is making sure that anyone who is receiving services really does need those services. But the insurance companies are not getting paid enough money. They do need more money in order to adequately protect our seniors and our disabled. So I'm out of time, but I look forward to all of your questions, and I thank you for having me.
Okay, thank you so much, Michelle. I want to introduce now our second speaker, Nancy Gaska, who is also an entrepreneurial woman. She owns her own business called WizdomCare Senior Solutions. She's the founding person and president. Right. She is presently, as I said, the president of WizdomCare Senior Solutions, is a full-service Medicare plans agency. She has over 6 years of experience in the insurance Medicare field. She is licensed life and health insurance agent and is one of the board of the Townwide Fund of Huntington. Her personal goal for all of her clients is to provide exceptional service by putting the needs of her clients first and foremost in all times. Ms. Gaska received her degree in computer science from Hofstra University.
Hi, good afternoon, everyone. Colette did an excellent job telling about how Medicare is being funded, where it's going. But let's talk about you. Where is your money going in the Medicare system? So what happens is as soon as you turn 65, and if you or a spouse work 10 years or 40 quarters, you automatically get Part A of your Medicare. Part A of Medicare is your hospitalization, skilled nursing, and hospice. Keep in mind, under Part A of Medicare, any prescriptions that are administered to you while you're in the hospital are actually covered underneath Part A. Okay? Part B, you pay for every month. Some people are grandfathered in and pay $104.90, but as you age into Medicare, it's now going up to $134 a month. And most of the time that comes out of your Social Security check. Now, Part B is optional because if you're currently over the age of 65 and you're still working and your employer has employer group coverage for you, you do not have to pick up your Part B. You can wait till you retire. Most people do pick it up when they turn 65, and how that works is Medicare will pay 80% of those costs, and you would have to pay the additional 20%. So basically, for every $100 of Medicare costs, you will have to pay $20 out of your own pocket. During the Bush administration, H. Bush, he created what they call Medicare Advantage plans. Medicare Advantage plans are what they call your Part C plans. Medicare Advantage plans, they're a pay-as-you-go plan. They include additional benefits that Medicare does not offer, such as dental, vision, hearing, gym memberships, such as silver sneakers. And that's pretty much it. Hearing aids, okay? Now those plans are what they call health plans. Medicaid or Medicare, CMS, has to approve those plans every year. So some of you might have an Emblem or an Empire plan or an Aetna plan, and those are health plans that are reviewed every year. They are not guaranteed from year after year. It's something that you have to understand. 2 years ago, Empire pulled out of Long Island and left over 80,000 seniors without insurance because those are health plans. They're only guaranteed on an annual basis. The other thing is what they call Medigap plans. Medigap plans are known as Medicare supplemental plans. They work on letters from A to N, and each one of these letters has a cost associated, and it'll pick up certain pieces of your Medicare Part A and Part B. Okay, so one might pick up hospitalization, but it won't pick up your extra days in a skilled nursing facility. So each one of these are, how can I say, they pick up pieces of each of the Medicare items from Part A and Part B, and they'll pay for them. So currently in the Medicare system, the plan that pays for everything, no co-payments, no excessive charges. Excessive charges are charges over and above the Medicare approved amount, would be an F plan. It runs about $280 a month. It uses Medicare as your primary insurance, because if you look on your Medicare card, it says medical insurance on it. So a Medigap plan, a supplemental plan, is also health insurance. So even if they don't offer these supplemental plans anymore, you are still grandfathered in, and you will have those supplemental insurance plans until you give them up. The plans from A to N, there's going to be some letters missing in between. Those are retired plans, and it means people are still out there using them. And the reason why they're retired is because they're good plans and they don't offer that. So in the year 2020, the Medicare Supplemental F plan will be grandfathered. It's going away. Okay, so if you have it, your grandfather, you have it for the rest of your life. It just means that new people going into the system will not have it available to you. Okay? Medicare Part D, which is your prescription drug plans, those are built into the Medicare Advantage plans, but if you have a Medicare supplemental plan, you'll have to pick up a standalone PDP, prescription drug plan. Now, the cost of drugs have skyrocketed. Some seniors are on very, very expensive drugs. There is assistance programs out there that can help you, such as the New York State EPIC program, and I left the brochures on the back table. If you qualify for the EPIC program, you pay no more than $20 for your highest prescription cost. So if you're on a lot of high-end drugs, you wouldn't have to pay any more than $20 for them. Okay, that's a New York State run program. There's also additional help. There's something called low-income subsidies, which you can call your Social Security Administration and find out if you qualify for a low-income subsidy. And if you do, the federal government will assist you in paying certain costs, such as your Part D plan, Part D plans, your drug costs, as well as even your Part B. You may not even have to pick up or pay your Part B plan.
It's normal with Medicare and Medicaid.
Okay? Now, Medicare, not only is it for seniors, but it's for people under the age of 65 who are also disabled. Okay, so they will have the same benefits of under 65 if they're disabled as if they were over 65. Companies that are small business companies, this is something that the Obama administration, under the Affordable Care Act, has required that small businesses, so that's employees under 50 people, have to cover seniors in their health insurance. Okay, so it's up to the individual company, but they do have to offer something for seniors over and above Medicare. Okay, you might have to pay for it, but they can offer it. Now, as far as abuse in the Medicare system, abuse happens in many, many ways. It could be an individual going to multiple doctors for the same medical reason to pick up perhaps another prescription, or they have nothing else to do that day and they just want to go to the doctor's office. Okay, that's considered Medicare waste fraud. Also, Medicare fraud is doctors billing for services for individuals who never had that service done. Okay, so it's always important that you read your statements, even though it's in code, there's usually some kind of description next to it, where you can say, no, I didn't have that service, and it's up to you to call that doctor's office and have it straightened out. Okay? You should never be paying for services that you have no idea what they're for. You should always be calling the doctor's office. Okay? Is there any questions? I gave it to you in a nutshell.
We have questions.
Sure.
Okay, so thank you. So we prepared some questions, and if any of you have questions, I think we're a small enough group, you can just stand up and ask them, and I'll repeat it. Okay. So I'm just thinking where to start. Well, let me just throw this out there. Coletta just disappeared. She might want to bring in on this too. Let's see what you guys think. To what extent, to your knowledge, does the federal government use Medicare funds for other purposes? And in other words, are they taking that money out and using it to fund the war in Syria? I don't know.
When the Obamacare came into play, they actually borrowed $716 billion out of Medicare to fund the state health systems. Okay, so what they did was they sent out a grant to states, so states can do their own online, like right now we have the New York State of Health. Every state, if they chose to, can also do the same thing, and they took $716 billion out of Medicare, so it's fun that.
Okay. So that's money just gone, or it's a loan, you said?
It was borrowed.
It was borrowed. It was borrowed. It was borrowed. Okay. All right. How would a one-payer system increase or decrease the amount of Medicare and Medicaid fraud?
I don't think it's going to matter at all, because Medicare fraud is, I'm going to say, uncontrollable. You can't stop a person from walking into a doctor's office or multiple doctor's offices. You can't stop doctors unless they get caught from overbilling the system or charging for services that were never rendered.
Mm-hmm. So it's really up to the user to catch those things and ask about those things.
It's up to the patient.
The patient.
Yeah, to report any kind of Medicare fraud.
Mm-hmm. Mm-hmm. Michele, you want to add?
I agree with Nancy. I don't think switching back to fee-for-service, having a single payer is going to make any difference. Managed care, like I had explained, has been preventing some of the fraud, but most of the fraud, in my opinion, is for not seniors and disabled. It's people that are on the low income standards that are doing things to make themselves eligible, such as hiding income or resources or being married and not saying they're married, things like that. But seniors being the largest part of Medicaid spending, that's not where the fraud is coming from, in my opinion.
Mm-hmm. Okay. Do you think a move away from fee-for-service model would improve, I don't know, would it reduce fraud or would it improve quality of care?
Well, in New York State, we actually don't have a fee-for-service in New York State. Fee-for-service in the Medicare world is doctors agreeing to pay a certain cost based on a contract that's presented to them at the time of service. Mm-hmm. Okay, we do not have that in New York State. What I think you're really referring to is the Medicare Advantage plans. They're more of a pay-as-you-go plan that when you go to the doctor, you give a co-payment and they accept that service, which is usually a PPO or an HMO. But those, because they're done with private insurance companies, the doctors are actually, when they do their billing, because they're limited billing codes, can they commit fraud? Yeah, absolutely. United Healthcare is actually going through a major trial case now because of what they originally did when the Medicare Advantages came out to play. But those insurance companies have regulated and improved the process since 2005. And doctors are limited to the amount of money that they can get for a service. So they capped it.
Okay.
Okay.
For Medicaid, there There is still some fee-for-service recipients in New York State. We have both. It's currently mandatory to have be in a managed care plan when you're on Medicaid. There are certain exclusions, certain waiver programs that you are allowed to be in or qualify for that exempt you from it so you can receive fee-for-service. But I don't think either one of them, I think a lot of investigation and a lot of education has to be done to really figure out how to prevent fraud more efficiently.
Okay. Do you think lowering Medicare eligibility to 55 would improve Medicare solvency?
No, absolutely not. What was discussed is under the Trump administration, the changes to the Health Care Act is actually to increase the age to 75. Okay? And keep in mind, anyone, prior to this, if it goes through, will be grandfathered in and not going to take it away from you. But the reason that they feel 75 is a good age is the fact that people are working longer, they're living longer, and they're not collecting their benefits until later. So my personal opinion, 75 is a little late, but 68 would work too.
Okay. All right. Talking about other things that have been floated, and if you have opinions, pro and con about health care savings accounts.
Healthcare savings accounts are basically for people who are employed. I honestly don't have any opinions on healthcare savings accounts as far as my clientele. Like I said, I generally deal with seniors and disabled. They generally do not have any healthcare savings accounts. I know there are pros and cons financially to both of them, but from what I understand about them, they're very limited to what you can put into them per year and what you can spend them on, and what you could do with what's left. So I think if you could afford to do it and it benefits you when you're younger, absolutely look into doing that. But as you get older, there isn't anything, especially if you're ill, that a healthcare savings, it's definitely not going to cover what your expenses are going to be.
I need to address that because I am a professional that does health savings accounts. And really what it is, it's more geared to the high deductible health plans under the Affordable Care Act. So when you have a high deductible and you have employees, they put that money aside as pre-tax into a health savings account, and that money is all used for medical expenses. And when a person turns 65, that money can be used to help pay for Medicare premiums and supplement premiums.
So that's
Without
currently,
penalty.
so that's currently in place.
Yes, that's currently in place.
I'm gonna
You'll
get to that.
probably hear more about it when this whole reform of the health care gets done.
Okay, I would like to add to that. Okay, health savings for seniors that are on Medicare, they don't have them here in New York State. The plans do exist in other parts of the countries where if you were in a Medicare Advantage plan, you set up a bank account and they deposit, Medicare would deposit money into your account to help with those high deductible plan costs. The health savings plans for organizations, for companies, for people under the age of 65, those are usually tax-free accounts that you can use towards your medical savings. But what happens when you turn 65, you can exhaust the health savings plan, but once you exhaust it, you cannot put more money into it in order to pay for your Part B or pay for your additional expenses. You can put in money if you have family, however. So if your health plan can actually pay for your family's costs, but you will exhaust it on your own.
There is a way to get around that because as in my practice, clients can go into a brokerage account, an HSA brokerage account, which will take care of that problem.
Do you want to introduce yourself?
Sure. Rita Medallo Barrera from BMR Global Wealth Management Group. I am a certified divorce financial analyst, certified senior advisor, and financial planner and president, and also a licensed insurance professional for 22 years.
Thank you.
Thank you.
Okay, all right. Okay, is the ACA going to explode?
I don't think it's going to explode. I think it needs to be fixed. As I said, it's capitated, so everyone is getting the same amount of, each plan is getting the same amount of money per recipient, no matter what those costs of care are. So I think we need to figure out a better way to keep these insurance companies happy, have them get enough money to cover the cost of what they're putting out for our seniors. Because we already had one of the largest, longest managed care plans pull out of Nassau, Suffolk, and Westchester, which was GuildNet. GuildNet was around for about 100 years. They were the first in the managed long-term care game. And they're not getting paid enough to stay in this business. So they're pulling out, and it's currently causing a whole disarray in a lot of our clients, because now they don't know where to turn, and they may have received a live-in, say through GuildNet, but now if they get assessed by Aetna might say, well, just because GuildNet said you need a live-in, I'm not going to give you a live-in. I'm going to give you 6 hours a day. So now we have people who are getting a lot less care because these other insurance companies don't want to become like GuildNet and run out of money and not be able to afford to take care of patients. So it definitely needs to be fixed. I don't think it's going to explode per se, but it definitely, I don't think there's going to be enough money and enough companies who want to stay in this to care for people properly.
Okay. I had just heard recently from a colleague that there was a change last fall in I guess, reimbursement for hospital and rehab, length of stay, and that it had been shortened. Do you know anything about that? That they in some cases, people were leaving the hospital sick or skipping rehab and going home. Nurses are going into the homes now, and
hospitals want to, if they think they're not going to get paid, they're pushing a lot of patients out of the hospital. A new regulation had come around, which is still trying to get on its feet, to prevent people from being readmitted to a hospital within 30 or 60 days. Because this is a big problem. Hospitals are going to be penalized for any readmissions in under that time frame. And Nancy could agree with me. And the way I know Medicare on my end, on the Medicaid end of it, is that if you go into a rehabilitation center with a 3-day qualifying hospital stay, the first 20 days of your stay is covered in full by Medicare. Then days 21 to 100, there is a copay. You're not guaranteed 100 days, but you can get up to 100 days with the copayment. And the Advantage plans, or the Medigap plans, are beneficial to anyone who has a lot of ins and outs to hospitals and rehabs, because that plan, even though you pay monthly for it, does cover those days 21 to 100, which we have a lot of clients that are in and out, in and out, in and out, or they've exhausted their 100 days, and now instead of paying, what's the code? 124.50 a day from days 21 to 100. An AARP plan or other supplemental plan will cover that cost, so you can get 100 days of coverage, which is very beneficial. It's a private rate at a nursing home, any nursing home, is between $300 and $600 per day for the average rehab stay.
Yeah, there's something called excessive charges in Medicare. Those are charges over and above the Medicare approved amounts. So if you need additional services, certain supplemental plans will pick up those additional charges for you.
Okay. A lot, very complicated. A lot for people to understand. I think that all, Erica?
I have a question. I think, Michelle, you might have been the one that mentioned that there were very few nursing homes or assisted living
Medicaid
facilities.
assisted living.
I'm sorry, say it.
The Medicaid assisted living.
That there are very few Medicaid assisted living on Long Island, that there are some openings soon. Do you know what the barriers are for that? Is it because it's so expensive to live here, or?
It's a very long process. It's at least a 2-year process to get a Medicaid-approved building through Department of Health. They're opening an Amber Court of Smithtown, which is actually in Nesconset. They will have, I think, about 180 beds. You can only have less than 200 beds to have a Medicaid-assisted living facility. It's going to fill up. I mean, there's a wait list longer than the beds available, because the only other one in Suffolk County is Medford Hamlet, which is now called Braemar of Medford. And then there's one more in Port Jefferson, which is called Woodhaven. So in all of Suffolk County, there have been only 2 facilities. The other facilities, just like your Bristol, your Arbor, your Atria, those are all private. They cost anywhere from $4,000 to $10,000 per month. What is happening now, which is brand new, Bristol and Lynbrook, which is way out in Nassau County, has gone for approval of a certain section of their building to be deemed Medicaid. So they're going to have an ALP program there. It's been a year and a half and they still haven't gotten the official, but it's going to happen. But it looks like I think once this kicks off, some of the other private pay assisted livings may decide to do the same thing. Because what's happening is people, clients generally, they either have some money or have sold a house and have money, and they figure, well, mom can live in the Bristol for 5 years. We have enough money for 5 years. Well, mom's 95 and she's still kicking. So they come to us and say, well, I don't know what to do. I just went through $500,000. So these Medicaid assisted livings are very beneficial because there are people who are very well, they're just aged. They want to go to activities. They want to get their hair done. They have their mental capacity. They may need a walker or something, but they can be enriched by a life in an assisted living program. So I think we definitely need them. And we definitely need to encourage government to have more of these facilities. The private pay facilities want to keep people as long as possible because obviously that's how they run their business. But people are either going into a nursing home, they're losing them, or they're running out of money, so some of them are going into nursing homes unnecessarily also.
Did you look, Joanne, did you look? No. Okay, well, that's sort of a good lead into my last question. Most of us think about Medicaid as being only for the poor, but we know that most of that Medicaid health insurance costs are for the elderly or for the handicapped. How can we ensure access to health care for these two populations who are growing and living longer in this current environment? What should we be advocating for, I guess, and we should sort of then, what can we do in terms of writing our legislators or, just educating ourselves in terms of what we might face for ourselves or for family members that may need extended care?
I think education is key. I think a lot of people don't realize where a lot of Medicaid spending goes to. It's definitely very worrisome that people are, it's not a bad thing that we're living longer, but by living longer, we're outliving our financial planning. So I'm sure that's going to change with younger generations. Financial planners will try and ensure that we have definitely more money to secure care for ourselves as we get older. But we definitely can't cut Medicaid spending. Maybe there's a way to ensure that seniors and disabled get a certain proportion through the states, because each state is allowed to, allocate their funds the way they need to. Maybe there's a way through just the managed care plans for our seniors that are in home care and nursing homes. They get a bigger allocation of the money than the low-income section.
With original Medicare, when they refer to home health care, they're not referring to it as Michelle is talking about. Home health care is strictly for after a hospital stay. If you need your dressings changed, they will not bathe you, they will not cook for you, they will not stay with you for hours. They'll just come, change your bandages, and then they leave. So it's important that down the road with the financial planning that you do plan for maybe some long-term health care, because that will help pay for those additional costs. Or you seek Michelle's services to help with Medicaid, and that would also help.
Mm-hmm. Okay, you have a question?
I always hear the expression Medicaid expansion, but they never go into what it is.
The Medicaid expansion is not for the seniors and disabled. Medicaid expansion is under the Affordable Care Act and purchasing insurance through the exchange. So what they basically have expanded is federal poverty levels. They have a set federal poverty level, and they've gone to somewhere close to 200% over that poverty level to allow people to get certain deductions to pay lower premiums. New York State is an expansion state, so we did do that. But it's not
Is more people eligible to have Medicaid?
It gives more people credits towards premiums. So if a full price premium on the exchange is $500 and change, if you have a certain income and you qualify under the expansion, it will give you credit towards that premium, so then you might only pay half of the premium, depending on where you fall in the poverty levels.
Mm-hmm.
So it's basically, it's all in the exchange. It has nothing to do with being low income. It's expanding poverty levels to say someone who makes $30,000 gets this amount of credit. Someone who makes $40,000 will get a little bit less, $50,000 therefore, you know, going higher and higher until you pay full premium.
Mm-hmm.
Full premium for what? Your insurance?
Your
Health insurance. Yeah, this is health insurance for people who have either no insurance through an employer, or, you know, like I'm self-employed, I have it through the exchange as well. So, but it gives you, the expansion gives more credits based on your income.
Mm-hmm. Yes.
I'm asking this question for a friend of mine, okay? You have your spouse on a hospice program at your home and have an aide for 7 hours a day. What benefits do you get from Medicare, and how long does it last?
From Medicare?
Medicare, yes.
Repeat the question.
She had
Hospice care, you have a friend's husband who's on hospice care 7 hours a day.
Aide, you have
7
an
days.
aide for 7 hours a day.
Okay.
And how long is this going to last? I mean,
how long will they continue to pay for this?
He's going to be a while on hospice. He's going to, you know, he's
Okay.
already past 6 months.
Okay. Well, that's exactly it, because with hospice, they do evaluations to make sure that they're still on hospice, and they will provide services under Medicare Part A for the time that person is designated as being hospice care. So that will go on for as long as they are considered hospice. That's covered underneath Part A.
And how much money would you get from it?
What do you mean? You're not really getting, Medicare will actually pay the provider directly. Medicare is not going to pay the wife or the husband anything.
No.
They'll pay the providers.
But they're not paying that much, not right now, for
Is it capped?
It's not capped, not when you're under hospice. That's covered underneath Part A. Hospice is covered underneath Part A 100%. As long as you choose not to go into a hospice, a high-end hospice type facility, in that case, Medicare will say, hey, wait a second, because that goes on to the fraud level. So if you choose to do final stages of life at home or in a qualified hospice type of facility, Medicare will pay 100%.
pay what?
100%.
They'll pay all of it.
Well, they're not now. I'll have to have her talk to somebody about this.
Yeah, we need a little bit more information. But if he's been on hospice and off hospice on, you know, it depends on their actual circumstance. But in most cases, as long as they're considered hospice qualified, then Medicare will pay 100%. So we would have to find out what his particulars are.
Okay, thank you.
Yes.
How do you get involved? Are you a private, you know, please review my situation?
Me?
No,
Are you?
yes.
I am a life and health insurance representative, and with Medicare, I go through certification every year based on CMS regulations to help seniors. I'm under strict compliancy with how I can help seniors and the information that I can give to them. But you have to be a licensed life and health insurance representative. And
Why would I see you? How would I contact you? I don't know. If you, let's say, you know, things happen. How do I, you know, access a person like you?
Okay, so I have information on the back table. You can call me. I tell my clients, I have about 600 clients right now, a little over 600. I'm available all the time for them to answer questions. It could be regarding to their actual medical coverage. It could be what they're paying out. You know, if they had a procedure done, I can help them figure out why that is the way it is. And also to make sure that you're in the best plan possible based on your health needs.
The reason you would see her, I'm sorry to interrupt.
Sure.
Because I don't know if you're asking why you would see her. You would see her if you start to have expenses that your straight Medicare A and B don't cover. Like I refer to someone like her and to her for people who have those rehab needs in and out of the hospital, in and out of rehab, where you need additional coverage. So seeing someone like Nancy is good to get that additional coverage to lower your costs. Because right now, you might be in an HMO Advantage plan. An Advantage plan where maybe you have, was it like Humana or something? What's the one around here?
Yeah, Humana. Actually, there's most of the Advantage plans around here are HMOs. Some of them are local and some of them are national. And if they're a local HMO, it means that you can only get coverage in the state and county where you live. If it's a regional HMO, they provide services outside of your state and county, like let's say you're Snowbird and you go to Florida. If that insurance plan is offered there, they will provide you with coverage. But most HMOs are primarily within the states that work with them.
So I would see a person like you or you when
You have much more care need, and your current insurance isn't really effective for you, that you're having a lot of co-pays, or you have a loved one who's become ill and in a rehab, and it's not going to cover that rehab stint, but it might cover the next one. So we also suggest getting a good plan that Nancy can provide you with.
Yeah, what I do every year is I sit down and with my seniors and I evaluate their health needs versus their health costs.
Okay.
To make it beneficial for them. Either I might say, you know, you're better off staying where you are, or I might have to switch them to another plan that's more beneficial for
And
the
your
individual.
fee for service. Your fee for service.
No, I get paid by the insurance companies. I don't charge. My services are free, and I get paid by the insurance only if I switch a plan. And under laws of the CMS, I mentioned earlier that they're very strictly regulated. I get paid exactly the same regardless of whatever plan I would switch you in. That's why it's to my benefit for referral reasons is to make sure that my clients are happy in the right plan that they should be in, and making sure that there's not extra expenditures that are coming out of their pockets that don't have to be.
And what service do you provide that's different from, let's say, the social worker in the hospital who's helping, you know, arrange things, whatever those things might be?
Though they would help arrange Medicaid in some cases, but they don't usually help in putting you into an actual Medicare plan. That's really up to you. Also there's only certain times of the year that you can switch a plan based on certain situations. So from October 15th through December 7th is the annual enrollment period. And basically the annual enrollment period locks in your prescription drug plan. Okay, so that's why when people refer to the supplements that they can change during the year, you know, you can change anytime, you can join anytime, is because the Medicare supplemental plans are actually insurance. They don't fall underneath and they don't have a prescription drug plan in them. Okay, where the Advantage plans, you're locked into the Advantage plan because the prescription drug plan is built into the Advantage plan. So there's programs such as EPIC, New York State EPIC, that open up a window. So if you join EPIC, you open up that window where you can change your medical coverage. You can change your supplemental as well as your prescription drug plan.
This is all very complicated.
Come on.
Yeah, feel free to call me. I'll be more than happy to answer your questions offline.
So let me make sure, this is more of a kind of clarification from my part. Is that the Medicare Advantage plans are they're approved by the Medicare program, and they cover A and B. And then there's the supplemental.
Medicare Advantage plans are health plans that are reviewed every year and approved by CMS every year, Center for Medicare and Medicaid Services. They're annual plans, and they're all-inclusive plans. They become your primary insurance when you go into an Advantage plan. Medicare is always there, but it's considered secondary. So with your Medicare Advantage plan, if you're in a Medicare Advantage plan and you go to the doctor, you don't have to hand them your Medicare card. If anything, they'll give that back to you, and they'll take your HMO or your PPO plan. With the PPOs and the HMOs for the Medicare Advantage plans, the provider has to accept those plans. All right, which means that they're contracted with the insurance company to take those individual plans. Doctors will not see you, or they'll charge you the full cost of their service based on the Medicare fee schedule if you choose to go outside of
the network,
outside that particular network. Where Medicare as a primary insurance and having a supplemental like a plan A to N, which is such as United Healthcare, AARP, you might have seen it on TV, that uses Medicare as your primary. So there is no HMOs, there is no PPOs. It means that any provider that accepts Medicare will take your supplemental because the supplemental acts as a secondary. It's Medigap, fills in the gaps where Medicare doesn't pay.
Now, if you get the Advantage plan, do you still pay for, if you have to, pay Parts A and B Medicare?
Okay, well, you're not going to be paying Part A, because Part A, you automatically get that as soon as you turn 65, if you work 10 years, 40 quarters or 10 years. You still have to pay your Part B, because something has to subsidize the cost of those plans. So those plans are pay-as-you-go plans, but the monthly cost of them could be zero, so you could have a zero premium, and then it can go into 200 and change for Medicare Advantage plan. So what happens is when you pay your Part B premium, that money is rerouted into the insurance companies to administer those plans for you. So if you're paying somebody to do a job for you, it means that you don't want to do it and you're taking a step back. And that's basically how Medicare is working with these Advantage plans. They're taking the step back and letting the insurance companies run these individual approved plans.
Yeah, I have a question. To what extent are physicians on Long Island supporting, accepting Medicare, Medicare Advantage, or not, either? What do you see any trends occurring presently among the physicians on Long Island?
Well, the Medicare Advantage plans They provide a lot of benefits to the individual member, but they don't pay very well to the doctors. So what's happening over the course of the years, a lot of doctors are pulling out of these plans, out of these Medicare Advantage plans. And the thing about it is that these doctors can pull out any time they want. Okay, so you might meet with somebody, your doctor is in the network, and then the next thing you know, the doctor's not taking the plan anymore. And they're allowed to do that. Now, with original Medicare, though, once a doctor's in the Medicare system, they can drop out of Medicare, but why would they? Because the difference in the Medicare fee schedule are going to be paid by the supplemental plans or by the individuals. They're going to get their money, which is actually more than these Advantage plans are paying them.
So that's why I'm really
Okay, anyone else? No. Well, I want to thank you for coming, and I so want to thank both Nancy and Michelle for coming. We're so lucky to live in an area where we can draw on expertise such as yours, and I really, really appreciate the time that you've given us today. So.
Please fill out the evaluation. This helps us in planning future programs. It's on the back of your program, please.